Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
As soon as we have the mounting accepted, it's now time to move ahead with the actual adjustment procedures. Prior to the actual removal of structure from the cast, though, we have to analyze the centric occlusion position more carefully to determine which areas are to be left alone and which areas can be ground on to eliminate the eccentric slide. In order to analyze the centric occlusion more conveniently, it would be best if you put the shims back in the articulator. We'll do that now. Tighten up the element. This way you'll always have the centric occlusion the same. Now if we turn this around, you see that we have the post set at a bent angle, and that means that now if we open it up a little bit, we do have end play from side to side. So in order, and this is because the shims are in order to eliminate that, if you just turn your post back to 0 temporarily, then you eliminate that. See, then it always closes in the same position. Whenever you go back and check actual lateral positions or movements or the slide itself, you should always set it back to the bent angle that we're working with, and that's usually about 15 degrees with these Technic models. So for this stage, I'm going to set these posts back to 0 so that I'll have no end play and I'll always open and close in the same place. Following the successful execution of the mounting procedure and having the cast checked by an instructor, we are now ready to proceed with the occlusal adjustment of the cast. In order to do this, one first must record the reference position or the centric occlusion contacts on the cast, and in order to do that, the shims should be in the articulator to hold the upper member back in the centric occlusion. If we open and close the articulator in this position, a solid hollow sound is heard because the shims maintain the constant contacting of the teeth in centric occlusion. This makes it considerably easier than trying to do this movement without the shims in, because there is too much freedom in the rear members. The first thing that should be done is to take some ribbon and go around putting the ribbon between the teeth in such a way that it will mark the teeth for us. And by a repetition of taps on both sides, one will get a representation of where the teeth are contacting. Now we'll open it up, looking at the upper cast. And we can see marks that are present on the supporting cuss tips and a little bit around there, and down in the areas of the fossas and on triangular ridges. You have various contacts. You also have them on the lingual surfaces of upper teeth. And what one should do is go around, and if these marks are not real pronounced, and just put down additional marks to establish in one's own mind where the correct location of the centric occlusion stops are. Now these are the areas that we would not want to remove to preserve the centric occlusion so that the stability of the occlusion will ultimately be maintained. On the lower cast, one has the same areas marked. Now, these casts are orange, and so I was using a blue typewriter ribbon with it. Now, as you know, some of these casts have been already adjusted in centric occlusion, so the marks may be more pronounced than they are even on this particular cast. Now, this is the first step to establish where all of the centric occlusion contacts are. Now, upon doing this and having these locations marked on your cast, one then goes to the chart that has the picture of the full arch. Now, this chart has all 32 teeth on it, and I've placed X's where the third molars are just to avoid confusion. This particular cast does not have third molars. There's a legend in the corner of this that explains that the black marks should be centric occlusion, and the red marks are CR prematurities, and the blue are working, and the orange are balancing. And this is just to establish some degree of difference on the marks that will be present on the page. Now, the step one on this would be to transfer those marks that you've made on the cast into their appropriate locations on the chart. And from our knowledge of occlusion in this usual class 1 relationship, there is a centric occlusion stop on all of the cusped tips, and there's usually one down around the area of the fossa, maybe on either side, and there's usually one on the lingual aspect of the upper anterior teeth. And what you would do is be to fill out this map according to what your specific model is. And upon completing the location of all the centric occlusion stops, one is then ready to go on to the next step, which is the location of the centric prematurity. Now, we'll go back to the model, and the material that we use to spot the centric prematurity is the shim stock. Now, this again is very, very thin. It's about 5/10,000ths of an inch. And on these particular casts, sometimes we have to use a little bit bigger, thicker material. For this, you can use some piece of cellophane that's about twice as thick, or some tissue paper, sometimes about 4 times as thick, if you're not able to locate the prematurities with this material. Now, the articulator is now pulled into centric relation. That means that the balls are all the way forward to the stops, and you can see the slide that occurs. If I make the contact, the teeth are now contacting, and pressure downward brings the slide to bear. Now, this is the thing that we are going to be trying to eliminate, is this uneven, sort of unbalanced contact that causes the upper and lower teeth to slide on each other until they reach a stable relation in centric occlusion. Now, I have already sort of checked this out and have found that if I'm in centric relation, I will hold shim stock here in the area of 12, and a little bit in the area of 14, and a little bit in the area of 15. But if of all of them, 12 pulls the hardest of this. So I would then assume that 12 would be the area of premature contact on this side. Just to verify that there is nothing occurring on this side, we'll put it in centric relation and drag the shim stock through. You can see we've got a little bit of drag, but nowhere near the retention that occurs on the opposing side. Now, one would then take the appropriate marking paper and attempt to mark the area of the prematurity. Now, opening up the cast and coming in here on number 12, one can see that adjacent to the mark on this cusp tip, which would be a representation of the centric occlusion contact, there is a mark here on the mesially directed incline of this upper lingual cusp. And this is the area of the prematurity. And this is the area that would be removed. Now, down toward the area here of the marginal ridge would be the location of your typical centric occlusion stop. So the area of the prematurity occurs between the two centric stops, the one here on the cusp tip and the other one which would be down here toward the marginal ridge. Now, down below in the lower arch, we have a similar contact that has to occur on the lower teeth. But on the lower tooth, the mark on this bicuspid occurs very much closer to the supporting cusp tip, which by our rules of adjustment would immediately disqualify it as the likely place to do our grinding. So you always have to remember that there are two places that would have to be ground. One of the two places would have to be ground to eliminate the slide, and one is the lesser of the two evils. And in this particular case, when these two teeth are opposed in this way and the contacts being where they are, the tooth of choice would be the upper mesial incline of the upper lingual cusp. Now, if we go back up to the upper cast, again, we can see some marks on the incline of the second molar here, and also some on this oblique ridge of the first molar. Now, these were two other areas that lightly dragged when I pulled the shim stock through. And these are also areas that if I remove this initial prematurity, I would probably increase the degree of retention of those particular contacts. Now, they also have contacts down below in the mandibular arch. And these contacts, being on molar teeth, are probably not going to be as closely related to the supporting cusp tip as they are in the bicuspid area. Here we have a prematurity here on this little bit larger triangular ridge on this second molar, and we have something up coming toward the cusp tip here. Here on the lower first molar we have a mark, but this is a little bit too close to the supporting cusp tip. So on lower teeth, one would be likely to grind this particular mark off because it's toward a non-supporting cusp and in a incline area, and one would be wise to avoid grinding in this particular area because it is toward the supporting cusp a little bit too much. So what I will do now is go to the upper cast and remove a portion of the interference that I marked with an instrument in an attempt to remove the deflecting contact from this. And you can see how nicely the white now then shows through where we've contacted, where we've worn through. Now, what one should have done just prior to this, of course, was to go back to that chart and put down in red where the locations of your initial prematurities were, so that you would have red marks in the areas that I had pointed out on the cast that would be the equivalent of the marks on the cast on the legend paper. Grinding this one particular area out, I then take the shim stock again, close the articulator back into the centric relation contact, and attempt to draw out the shim stock, which now occurs with ease on tooth number 12 and is restricted on 14 and restricted on 15. And this is what I told you would probably happen once that first prematurity is removed. So what we would do is go up to the area of the second molar and first molar in the upper. Taking a look at this, one has this oblique ridge on the first molar that is quite a common occurrence, especially on a poorly designed first molar crown, the tendency is to make this oblique ridge anatomically prominent, and the lower molar does not realize how fortunate the person is to have an anatomically prominent oblique ridge, so it cuts a facet in it. So we remove this particular offensive area, and on the second molar we have a similar contact to what we had on the first bicuspid, and so we'll do the same thing that we did to the area of the first bicuspid, is remove a portion of this incline to change its shape to try to avoid the prematurity in contact that is occurring. Now, closing the cast, one would check to see how much centric occlusion slide one has, and it's still pretty much the same as it was before. Now, it's important that one keep track of what's going on down here at the incisal pin, because this pin has set so that when the teeth are in centric occlusion, that is in their stable contact, this pin is on the table. And if one looks at the pin when I put it in the centric relation, not only does the pin go forward, but a space develops between the pin and the table. And you can see that this space closes as it goes into centric occlusion. When the pin is off the table, this is in centric relation. When the pin goes down to the table, it is in eccentric occlusion. Now you'll notice that the pin does not move laterally like this on the table. It just goes straight forward and back. Now if it went laterally, that would be a representation of a lateral slide in centric. So this particular height in centric occlusion is ultimately where you're going to wind up very close to in centric relation. So one can see how close one is getting to completion by watching the amount of space that is still present when you put the case back into centric relation. And as I said, these three adjustments that I made have not really significantly dropped the pin to a closer contact to this incisal table. So one goes back to the shim stock and attempts to locate where the prematurity is. Now here we've got 15 is still quite heavy, 14 lets it draw, 13, 12 draws. The anteriors, of course, still draw. To the other side, 2 draws, 3. Oh, we got something here on 4. So now we got 4, a little bit of 5, and 15 that are inhibiting the passage of the shim stock. So one would mark 4 and 5, slip around to the other side and give 15 a hit or 2. Now you notice that I've been flipping this ribbon over. This is the one-sided IBM tape, and this is just about as thin as the shim stock, but it has ink on one side, and being black and being highly flexible, it's quite handy for doing this. But you have to do it 2 times. You have to do it once for the lower and then flip it over to do the upper teeth. Now if we go back up to the upper again, we take a look at this. I was suspicious of this mark here on this lingual aspect of this cusp initially, and this is an area that we don't want you to grind over here. And when I go down to the lower, I'll point out where that was. The more astute individuals in the class have already realized where that is. It is on that triangular ridge that I pointed out on the lower second molar. Now, as we come across to the other side, where we get into 4 and 5, we also notice that there's a similar contact out here on 3 in these particular areas. Now these areas of these upper teeth are always contacting your non-supporting cusp on the lower. So when you see contacts here in centric relation, one would then feel that the lower triangular ridges on those supporting cusps are going to be altered. And this is a contact on 4. And 5 is a little lighter, but it's in here. So these areas would then be transferred to your chart in red as your prematurities. Now going down to the lower, coming back over here to 18, this contact on this triangular ridge is the one that I pointed out on the upper lingual cusp. And this is the area that we'll remove first. We will reshape this area. Now this is a distally directed surface. We'll remember that the distally directed surfaces of the lower teeth are clashing with the mesially directed surfaces of the upper teeth. So when one is adjusting a straightforward slide in centric, it would be very unlikely that one should be adjusting a mesial surface on a lower tooth. If one's doing that, this generally means that they're not watching what's going on very well. On the other side, on the lower, here we have the prematurity from 4 is down in this area of 29, and the prematurity of 5 is on this area of 28. Now, this area here we would avoid being close to the supporting cusp. One would probably take a little of this off of 29 because it's in the area of the non-supporting cusp, and it can be removed. Now, I'm not going to do anything with these marks back here on the lower molars at this particular time because, as you remember, when I went back and pulled the shim stock through, they were not making contact, so that may be an artifact at this time. Going back up to the upper cast, as we said, we wouldn't remove anything from 28 because of its location very close to the the lower supporting cusp tip. Here is the mark that is made on this particular tooth by the lower. It's in this particular area. You'll notice it's on the incline. Here's where the centric stop is in centric occlusion, so by widening this area out, one would expect to decrease the degree of interference between these two. Now, we would then go back down again, close the articulator, and see if we're any closer to our result. And I'm not overjoyed with the degree of progress I'm making at this stage. One would then continue. This is often likened to the removal of the wobble of a bridge table. To see, there's 15 dragging, 14, 12, and 13 are open at this time. 2 is open. Now 3, this is one of those contacts again. 4 opens, and 5 is now open. So at least I am removing the teeth that I do adjust from contact. Now that marks that side, and then we'll go back here and do 15. Now here I'm doing something a little differently. I'm letting the cast slide into centric occlusion from the centric relation. Before I was just holding it in centric relation. So one would expect now, instead of dots to develop, when one goes back and checks, to have some sort of a linear pattern developing with this. Okay, we're going to go down to the lower to check out where these contacts are, and we'll go over in the area here of 18. And here we have, this was the area very close to the first area that we ground. We now have a development down here. Now this looks like it's the bottom of the fossa, but it's actually a little bit forward, and it is, looking at it closely, a little bit on an incline. So one would remove to let this upper cusp fit into there more comfortably. Now on the other side, in the area of 30, I said that we were starting to get a drag on 3, and what has happened is that 3 is now dragging on this mark here, and this incline would be reduced to allow the cusp to get in. Now, up above, going over here to the area 15, one notes that now we're getting an oblique ridge contact here on 15. That is probably contributing to the slide as it was initially on 14. So this oblique ridge should be carved back out of the way. Again, this is a measly directed aspect of the oblique ridge because it's an upper tooth. If one saw it was a distally directed aspect, one would have to conclude that the mark was extraneous or made in centric occlusion rather than a centric relation. But this is why we're having you use the different colors on the chart so you can see the difference, and you're essentially using the same color on the models for the sake of definition. You can't use the different colors because of the orange paint, but knowing what is the correct positions on the road map, you're able to sort this out. Now, we'll go down again and check to see. Now I've made a perceptible difference in the slide. It doesn't go quite so far as it was doing before. We'll go and check where the prematurity is now. I don't know, 15 looks like it really wants to get a pulp exposure out of this whole thing. 14 is starting to pick up again a little bit more. Now we're back on 5. 4 is wide open. We've got some of 3 again, and nothing on 2. So we'll go back and mark 5. And then I said 14 and 15 on this side. And we'll open up and check up the upper cast first. And 15 and 14, what's developed here is 14, more of this oblique ridge toward the buccal has started to mark. Right here. And on 15, we're on this prominent edge of the lingual cusp. On the other side, we said there was some contact on 5. 5 is now having an additional contact on the rim of where I had ground previously. This is quite a common occurrence. When one removes the initial prematurity in a particular area in making the concave shape that we make, we are not surprised to find out that the rims of the areas are contacting. Down below, one checks out in the area of 18 and 19 and finds that the marks are a little bit too close to the lower supporting cusp tips to do any grinding down there. One will continue to grind on the upper teeth. Going across to the other side on 28, the mark is even closer to the cusp tip of 28, and so we would, at this particular time, still be leaving this area alone and doing our grinding on the upper. So I will go up on the upper and remove some more of these areas. To try to allow the lower buccal cusp to seat more distally in these upper fossas without reaching premature contact. And closing it again. And notice that the pin is closer than it was initially. And now you notice that there's a certain development of a freedom here. The pin does not raise up as much as it did before. But because we've been doing this adjustment, we've been freeing the contacts between the individual teeth, and so it slides frontwards and backwards. This is the long centric that we're gradually developing. So what we'll do now is fade to black. I'll continue to adjust this. When we come back, I will have the case adjusted, and we will demonstrate the areas that have been ground further. This chart is the second portion of the two-part sheet that comes with every case that you adjust. This is the written record of where one is doing the adjustments, because that roadmap has all the marks on it, and there is really no sequential presentation, because when you're finished and the chart is all covered with the colors, one does not know where the first prematurity was, the second, how many times it was ground. So this chart is divided into 4 portions: centric, working, balancing, and protrusive. This first column deals with tooth number, location of grinding, and then here we have amount of tooth structure removed. I guess that must be in kilograms. What we usually put in that box is a check every time the tooth is ground. So I believe I said our first prematurity was number 12 in centric. So the 12 would go in this particular area. The location of the grinding, well, let's see, it was the mesial incline of the lingual cusp. Now those may be your own kind of abbreviations. I put down the mesial, for M for mesial, L for lingual, and C for cusp. And the amount of tooth structure removed, well, I hit it 1 time, and I think I hit it 2 or 3 more. I put down 3. And then we also we did 14 a little bit, and 14 we did the mesial incline of oblique ridge. In my OR, you'll get some weird anagrams probably by this. I hit that 2 times. And we'd rather have you do this step by step rather than an examination of conscience after the grinding is done, and a presentation of your record that way. And when one finished with centric, you'd have all the teeth ground, would be down on this chart, and this would be in the sequential order. Now this is in the beginning, or when one is not really experienced with occlusal adjustment. This helps in the transfer from the cast to the working model in the mouth, because you can't expect this thing to work out exactly step for step the same. But if one is working on the right side for a while and then it expects to be changing to the left side, then one can sort of expect it to follow a similar pattern in the mouth. Now, it is not a completely reproducible thing, but it does follow quite closely in many instances. Now, this model is now just about completed in centric. The pin is very close to being on the table in centric relation, and you can see that the passage between CR and CO, the pin virtually follows it on the table. And there is a freedom. This is a long centric. There isn't much of a broad centric here because there wasn't a lateral slide. But here we have the long centric, and you can see this moving. Now there is no inhibition to this. These teeth are not rubbing in such a way that it makes a zigzag pattern or individual teeth may be hitting higher than another. But if one wanted to refine this a little bit further, to say have the pin be in more intimate contact in the centric relation position, what one could do, it'd be to lock the articulator balls forward. Now this restricts the articulator from going anywhere but in centric relation closure. One would go around with the articulating paper. Prior to this, one would take the shim stock and assess, well, do I have a contact here? No, no. Don't have any contacts along this side. That's 12 through 15. We go on here. Got a contact there on 4 and 3 and 2. And finding that out with this locked in CR, one would mark. Now this is locked in CR, so none of the centric occlusion contacts can be marked. So if one finds a contact that's on an incline or in the areas of fossas, one can easily grind it because of the lack of fear of removing a centric occlusion stop. Now here on the upper teeth, we've got this contact here is probably our prime offender on number 4, right in that area. Number 3, it's the oblique ridge again. Now, as I say, this model is just about done. If you leave this shot right here on, you can see how little of the orange is actually removed from these casts to grind out quite a large slide. Now that pin was off almost a complete millimeter off the table when we started out, and one still sees that there is a great deal of orange still intact on this cast, and there's no supporting cusps that have been unduly undermined. You notice the front teeth are void of any mark at all in terms of removal. One would find it unusual for the lower or upper teeth on the inside to have contact. You can see on the lower cast how much of the orange is still intact. So in a judiciously applied, the rules of occlusal adjustment maintain a good deal of tooth structure. And if one realizes that the patient who's grinding their teeth, and we'll stay on the upper cast, the patient who is grinding their teeth is actually wearing out 2 teeth simultaneously, and theoretically, if one correctly does an occlusal adjustment, one ultimately is conserving tooth structure by removing only one of the interfering contacts and preserving the other. So one would then adjust this area of incline out, and in this area the oblique ridge on the upper, and some of this area on number 2. And for a real fine check, one would continue to do this until in centric one dragged on both sides about equally. So we've got more contacts there. Again, the articulator is locked in centric relation, so there is no possibility of marking a centric occlusion stop other than a cusp tip. And as I said, cusp tips we don't attack anyway, so there's not really concern for removal of too much of that. One would adjust a little bit more these areas of inclines, as I say, that produce a contact. A little bit of this marginal ridge, some of this oblique ridge, a little of that. Down below, a few areas around the fossas to let those large lingual cusps come down. Now I've got 3 of the 4 teeth on that side to drag. And 3 of the 4 teeth on this side drag with a little bit heavier down here on number 5. So I'll just take this one little bit of 5 off. And as it turns out, I'm going to take it off at 28. And this is a difference here. We go down in 28. Remember in the beginning I was talking about not going up into this area, the supporting cusp. And you notice there is some white removed right here. Now this is down toward the bottom of the fossa, and our last little bit we're going to take off is off this non-supporting area over here. Let that go. Now the sound is much more solid here in centric relation now. And to check, we can drag 3 on that side. And we get all 4 on that side now. So this is the illustration of the refinement of our centric relation adjustment. Now we have a uniform contact of the teeth in centric relation. It's a solid. The proprioception is now more harmonious, or better able the patient to adapt, because one is not banging on one isolated tooth and sliding. One can open and close the articulator in centric relation, exert a downward force, and get no movement. The centric occlusion, the centric relation occlusion is now stable. If the musculature would like to go to centric occlusion, this is possible by just protruding the mandible, and this is essentially in the same horizontal plane. Due to the small size and relative ease of removal of stone in a natural size set of cast, stone is usually removed as it was previously with a sharpened knife or a sharp waxing instrument. These casts, being as large as they are, lend themselves to using a handpiece and a small rotating green knife-edge stone, which I have here in the handpiece. The larger sizes, being a 3-to-1 magnification, means that greater amounts of stone have to be removed, and it may be easier for you to use the rotating stone for removal of the tissue on the cast, and this would be just applied to an area that you had an interference and lightly removing the amount of tissue. This would be less danger of possibly chipping it that you have with the knife, because you have to bear down and you might remove an excessive amount. Just a gradual, small removal of this. You can contour these shapes to the dished out area, making the more distal seat in the upper tooth for the lower cusp and the more mesial seat in the lower tooth for the upper cusp. However, the method, or whichever method is used to remove the tissue, it should be removed in such a way that when one finishes, one has a even, stable contact in centric relation, and there is no sliding, slipping, or tripping of the cast from that position. Upon this step, one has completed the adjustment of these casts in centric relation, and one would proceed to the adjustment of the lateral excursion and the protrusive.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.